Hello friends, today we are going to discuss regarding echocardiography findings in a patient with mitral regurgitation. So the purpose of echocardiography in mitral regurgitation is number one, to confirm the diagnosis of mitral regurgitation. Number two, to identify the etiology of mitral regurgitation. That is whether it is rheumatic, ischemic, congenital or degenerative. Then to quantify its severity, if it is mild, moderate or severe mitral regurgitation. Fourth, to assess LA and LV remodeling and function. Guide treatment regarding intervention. And when should we go for intervention in a patient with mitral regurgitation? It will guide in timing of intervention. So, structural anatomical changes in a patient with mitral regurgitation. So, in mitral valve, there may be typical findings may include prolapse, flail mitral valve, or thickening of mitral valve, as in the case of rheumatic heart disease. In cases of chordate there may be rupture, elongation, or fusion of chordate. In papillary muscles, there may be displacement and dysfunction of papillary muscles. In mitral valve annulus, there can be dilatation and flattening. There can be enlargement of left atrium due to volume overload condition. And in left ventricle, there can be dilatation and enlargement due to volume overload condition. Now we will go through the classification of mitral regurgitation. Number one, classification of mitral regurgitation by color Doppler regurgitant jet volume with respect to LA. So it can be divided into three types. So if the regurgitant jet volume with respect to LA is less than 20%, then we label the patient to have mild MR. And if it is between 20 to 40% of that of LA, then we label the patient to have moderate MR. And if it is more than 40%, then we label the patient to have severe MR. Then we can classify it into three types on the basis of jet. So on the basis of jet size, in case of mild MR, it will be small and central jet. In case of moderate MR, it is of moderate intensity, it reaches up to mid LA level. And in severe cases, it can go up to posterior wall, and jet is severe. Now we also look at whether there is dilatation of LA and LV, which are the other supportive findings that we may encounter in a patient with mitral regurgitation. So in mild MR, there is no LA or LV dilatation. In moderate MR, there may be mild to moderate LA and LV dilatation. And in severe MR, there is marked LA and LV dilatation. Then classification of mitral regurgitation on the basis of vena contracta width. So if vena contracta width is less than 0.3 centimeter, then we label the patient to have mild MR. If it is between 0.3 to 0.6 centimeter, then we label the patient to have moderate MR. And if it is more than 0.6 centimeter, then we label the patient to have severe mitral regurgitation. Then we have to look at ejection fraction and left ventricular and systolic dimension in order to decide if the patient requires surgical intervention or not. So if left ventricular and systolic dimension is more than 40 mm or if ejection fraction is less than 60%, then surgical intervention may be required. Now we will go through ECG findings in a patient with mitral regurgitation. Number 1, left ventricular hypertrophy. As we have already discussed, there is regurgitant jet in MR which goes up to LA and it will cause volume overload of left atrium. So patient will develop left atrial enlargement. It can be manifested as P mitral, that is broad and notched P wave in lead 2. Second, left ventricular hypertrophy. So chronic volume overload condition will lead to left ventricular hypertrophy and dilatation. There can be tall R wave in V5 and V6 and deep S wave in V1. So Colo-Leon criteria. So the sum of deep S wave in V1 and tall R wave in V5 or V6 if it is more than 35 mm. Then left axis deviation due to left ventricular enlargement, and if R wave is dominant in AVL if it is more than 11 mm, and features of left ventricular strain pattern, that is ST segment depression in V5, V6, 1 and AVL. Number 3, atrial fibrillation. So in mitral regurgitation, due to dilatation of LA, patient may develop atrial fibrillation. Number 4, right ventricular strain pattern and right ventricular hypertrophy. So in a patient with chronic mitral regurgitation with long standing pulmonary hypertension, we may find features of right ventricular hypertrophy on ECG. So there can be right axis deviation and T-wave inversion in lead 2, 3 and AVF and in precordial leads V1 to V3, and dominant R wave in V1, R upon S ratio is more than 1. Thank you.